Hello and welcome to the July 2020 National Immunisation Programme update. My name's Angelina Boswell and this is Nancy Goncalves, and we are both public health nurses at Tropical Public Health Services in Cairns, working for the immunisation programme. We would firstly like to start by acknowledging the traditional custodians on the land of which this event is taking place today. We pay our respects to elders past, present and emerging. Due to COVID-19, we're filming the presentation. We're not in the Cairns auditorium today. Hopefully we'll be back there next year for the update. So this presentation is going to be filmed. I'm going to present the National Immunisation Programme update, and Nancy's going to specifically present the medically at risk category and the cold chain update. All right, so we'll look at the contents of what the information we've got to give to you on this education session. There's quite a lot to get through. We've had a lot of information received from all the different ATAGI statements and the Immunisation Handbook, the information from the National Immunisation Programme. So we've tried to break it down as much as we can. There's a lot of very busy slides, but that's just because we're trying to get as much information across to you guys as possible. So we're going to have a look firstly at what the new schedule looks like. I'll show you the pictures of the schedules. They're not officially on the website yet, but they should be in the next few days. And then we'll go through what the changes are. And there are changes to the children's ATSI schedule, so we'll break those down and have a look at those. There are changes to the pneumococcal eligibility, and that's for Aboriginal and Torres Strait Islander children and adults, and for medically at risk, and for your non-medically at risk and non-ATSI adults. And then Nancy is going to more specifically look at medically at risk, and then Nancy will go through some cold chain as well. All right, so for this is what the immunisation schedules look like. So this time they're 2 pages as opposed to the 3 sheets that we had on the ring binder last time, and they're going to be in size A3, and there's a lot of information on these 2 pages. So the first one on the left hand side is the children's schedule, and the one on the right hand side is for adolescents and adults. So I'll just go through the children's schedule. So just across the top there's a bit of information about before you vaccinate. So that's getting you to look at air, make sure right patient, right vaccine, just be as clear as possible about what you're going to be giving to your child and whether they're eligible or not. There's a little square on the right hand side that talks about whether the vaccine will need reconstitution or whether it's going to be given IM or subcut. And then down the left hand side in the blue boxes is the age points at when the child comes in. So that's all same as usual, those age points. Then it's got the actual diseases down the next column, and then the third column has got the vaccine brands. So if you look down, you do notice that it's got every single vaccine listed in all those age groups. So to work out who's eligible, you have to move across to those boxes. So the green boxes are for all children. So all children, whether they're Indigenous, non-Indigenous, medically at risk or not medically at risk, it's your standard national immunisation programme that we're always giving. So that's in the green boxes. So for example, your 2 and 4 months, you've got your Influenzae, your Pneumococcal and your rotavirus. They've all got green boxes at the side of them, and that's what we're used to giving. The next boxes that you move over to are the orange coloured boxes, and the orange boxes are for Aboriginal and Torres Strait Islander people. And so you have to work your way across. So you can see at 6 months, the Aboriginal and Torres Strait Islanders get pneumococcal vaccine, which we're used to giving. And if you go down to the 4 years, you can move across there. You can see that there's an introduction of Pneumovax 23 introduced. So that's now has an orange square at the side because that's for Indigenous patients, children. And Hep A has been moved. That's also in the orange boxes. So previously there was a nice bright yellow highlighted line across Indigenous vaccines. It's a shame that's not there because that was really handy and it really highlighted what they required. But these, for your Indigenous families coming in, your Aboriginal and Torres Strait Islander children, you really need to study the schedules and look across to those boxes and make sure that you are giving the right vaccines and that they're receiving the vaccines that they're eligible for, and that you're not giving ATSI funded vaccines to ATSI children. So you do have to look a little bit more carefully. If you move over then you've got the purple box. The purple box is for medically at risk. So at 6 months, we know that if you're medically at risk, you get pneumococcal. At 12 months for premature babies born under 2,000 grams or under 32 weeks, they get the additional hepatitis B. And then if you go down to 4 years, you can see that medically at risk children will also receive a Pneumovax 23. That's new and been introduced onto the schedule, which we'll talk about later. There is a section across the top in purple that says important. It goes across the top of the schedule, and that's to let you know that children, both Indigenous and non-Indigenous, if they have certain medical at-risk conditions, they are eligible for Meningococcal B and Meningococcal ACWY. So that's new, but the criteria is very small. So we'll go into that criteria later. So it's not just for anybody with a medical at-risk condition. It's a very, very specific, very small criteria. So they haven't actually added the purple boxes in for all those children that are going to be eligible for that. So it's up to you to look and see what the child has been diagnosed with, and then look and see if they're eligible for those vaccines. And Nancy's going to talk about medically at risk a little bit later. And then if you move on to the next column, it's just telling you where the vaccine should be given. And then the final column has just got notes about the specific vaccines and eligibility. So that's the children's schedule. If we move over to the adults and adolescents schedule, there's a lot of information on that now, whereas previously we had the separate forms. Now everything's been condensed into one schedule. So the top section, where it's got the blue down the left-hand side, it's got the school-based vaccination programme, pregnant ladies, older persons eligibility, and if you move across, it's got the green squares again, so that means everybody, and then you'll notice there's some orange squares, and that's for the people who are eligible who are Aboriginal and Torres Strait Islander, and it's got a section with quite a few notes down the right hand side. The purple section across the bottom, that's for the medically at risk, and again, as I said before, Nancy's going to go into that in a little bit more detail. The bottom left hand corner is influenza and who's eligible, and the bottom right hand corner is your refugee and humanitarian schedule. So we're going to break it down as we go through the PowerPoint, but it's really important that you have a good read and look at all the little sections of criteria, because it's, as I said, it's very busy and a lot of information squashed into 2 documents. Okay, so 6 ATAGI statements have come out for this schedule, so there's a lot of reading matter. It's really important that you read through everything. As I said, the eligibility and criteria has changed a lot with this July 2020 schedule, so just take the time, have a good read. We've tried to break it down into this education session. We only got the ATAGI statements not long ago, so we've really had to sort of try and condense this as quickly as possible and just hope that we haven't missed anything, but we've done a lot of reading. Also, there's the National Immunisation Programme have produced their own fact sheets. That's the one that's on the far left-hand side. They break down all the information really nicely. They've been really helpful for us to get the schedule off the ground and understanding it. And then all the other pictures that you can see, they're the Australian Immunisation Handbook infographics. So they're all available online, and the infographics break everything down again quite nicely, make things a little bit clear. But just remember, they are Commonwealth, and we follow the Queensland Health Immunisation schedule. So just make sure that you're always referring back to, even though you're using these infographics and extra information, just make sure you're always going with what the Queensland Health Immunisation schedule says. So the changes are, there are vaccines that have been changed, are the meningococcal vaccine, the pneumococcal vaccine, and hepatitis A. We've seen changes in all of those vaccines. So there are no changes to the non-Indigenous national immunisation schedule, so that's one less thing to have to think about. But there are changes to the Aboriginal and Torres Strait Islander eligibility and criteria. There are also changes to medically at risk eligibility and criteria, and there are changes to the older adult recommendations. So we'll go through those. So Meningococcal B vaccine has been introduced for Indigenous children under 2 years of age. And Meningococcal B has been introduced for certain medical at-risk groups. Hepatitis A vaccine has been moved, still available, but it's been moved to a different time. And there's now funding for meningococcal ACWY, and there's also funding for HIB, but again, only for certain medically at-risk groups. Pneumococcal, there's changes to the timing and eligibility for Prevnar 13 and Pneumovax 23. And the pneumococcal table, the recommendations have changed from category A and category B to one big long list of, and instead of the two categories, it's broken down into recommendations and what's actually funded and not funded. So meningococcal B disease in Australia. So this graph is taken off the government website. It is from 2002, but it only goes up to June 2019. I didn't manage to get one up until the end of the year. And meningococcal B is the red colour. So you can see that that red colour has dominated all the way along since 2002. Meningococcal W and meningococcal Y, they both increased in late 2016 and early 2017, and that's when we introduced the Indigenous programme for the meningococcal ACWY vaccine, and then that went on to become part of the national immunisation schedule. So we can see quite clearly that meningococcal B has always been high rates. So meningococcal B disease, it remains the most common cause of invasive meningococcal disease in children, adolescents and young adults. Meningococcal B disease, it's a rare but serious infection, and it's caused by the bacterium Neisseria meningitidis. Septicemia and meningitis are the most common clinical manifestation, and its serotype B is the leading cause of infant bacterial meningitis. So the mortality can be as high as 10%, and more than 30% of survivors do have long-lasting sequelae. Invasive meningococcal B disease is highest in young children, and it's about 4 times higher in Aboriginal and Torres Strait Islander children, less than 2 years of age, compared with non-Indigenous children. So meningococcal B vaccine has been introduced onto the schedule in July 2020 on the 1st of July, and that vaccine is going to be Bexsero, and it's going to be funded through the National Immunisation Programme, and it's going to be available for Aboriginal and Torres Strait Islander children under 2 years of age. It's also going to be funded for medically at-risk conditions in children and adults. As I said, very strict criteria of who's eligible. And I just wrote a little note on the bottom that Bexsero is available for private purchase, because word will probably get out that Bexsero is on the national immunisation schedule, and you may find that you get more parents asking for the vaccine, and only eligible children are going to receive the vaccine, but it is available for private purchase. Some people have been using it for private purchase for quite a number of years now. This is what the vaccine looks like. It comes in a pre-filled syringe, and it either comes in the singular boxes or boxes of 10. So there's no reconstitution with this vaccine. It's just a pre-filled syringe ready to go. The number of doses, so the standard schedule for Aboriginal and Torres Strait Islander children is 1 dose, and it's going to be given at 2, 4 and 12 months of age. So standard Aboriginal and Torres Strait Islander dosage is going to be 3 doses in total. Dose 1 can be given as early as 6 weeks, so it can be given with your other vaccines that you would receive if they come in early at 6 weeks. And the medically at risk children that are in that eligible criteria, that's Aboriginal and Torres Strait Islander medically at risk and non-ATSI medically at risk children. Their vaccine dosage will be 1 dose given at 2, 4, 6 and 12 months of age. They're going to get that additional dose at 6 months old. This is the medically at risk category that I've been talking about for Meningococcal B, and it's also Meningococcal ACWY eligibility. This is taken from one of those National Immunisation Programme information documents that they've produced, but this is also available on the ATAGI Statement, and it's also available in the Immunisation Handbook. But I'll just wait for Nancy to go into that a little bit more detail. There is going to be catch-up available for Aboriginal and Torres Strait Islander children under 2 years of age. So up until they turn 2 years, just before they turn 2 years at 23 months, they're eligible for their Meningococcal B vaccine. But if you're doing catch-up, you need to be careful that you're giving the right amount of doses, because children under 12 months of age will receive 3 doses, whereas once they turn 12 months of age, they'll only be getting the 2 doses. So just make sure that if you're doing catch-up, you look in the handbook, you follow the tables, and ensure that you're giving you the right amount of vaccines with the correct dose interval. And obviously, if they're medically at risk and they're still under 12 months of age, although there's a table, I'll go through that table in a moment, so it'll be clear if we look at the table. Here's a table. So the table on the left-hand side is without medical conditions, and the table on the right is with medical conditions. So for young children coming in under 11 months of age, 11 months and under, they will get 3 doses with the standard schedule. But if you've got somebody coming in for catch-up who's over 12 months of age, they only receive 2 doses. And with the 3-dose schedule, when they're starting it under 12 months, the 3rd dose has to be given at 12 months or over. So they get their first 2 doses 8 weeks apart, and the 3rd dose, it has to be given 8 weeks from the 2nd dose, but they have to have reached that landmark birthday of 12 months of age to receive that boost to give them longer protection. So just be mindful of that 3rd dose. A lot of people do a reminder, say come back in 8 weeks, but if they haven't reached 12 months of age, then they have to wait until they reach 12 months of age to receive that 3rd dose, the booster dose, which in the case of medically at risk, it would be the 4th dose. So if you go onto the table on the right-hand side, this is for medically at risk. And it says there, children coming in between 6 weeks to 5 months of age, they will get 4 doses. And it's got the dose intervals written there. And that goes on to go, that table shows you over 10 years of age as well. So it's the same table that we would use for adults. But these are available in the Australian Immunisation Handbook. So it's always worth just clicking on and having a look when you've got your patients with you, just while you work out your schedules. This has caused quite a bit of debate amongst vaccine service providers, the prophylactic Panadol, paracetamol, because we're not used to giving paracetamol for immunisations. Children under 2 years of age are recommended to receive prophylactic paracetamol with every dose of Bexsero. Spent quite a bit of time looking through ATAGI statements. I've looked through the patient information leaflets, the product information leaflets, and the handbook, and everything I've read all says that paracetamol is recommended to be given. I've not seen it written anywhere where that's not mentioned. So parents and carers, they need to be alerted to purchase paracetamol prior to administration. I've just put the little bubble in the top right hand corner there about early education is beneficial, and maternity units need to think about talking about postnatal the postnatal period when they're taking their kids for their vaccinations. Early education always gives parents greater confidence in vaccinations, and if you're educating them about paracetamol beforehand, then hopefully they'll have the paracetamol purchased and be aware of the vaccine and the requirements. The leaflet over on the far left, the yellow and white leaflet, we're going to make sure that maternity unit has those leaflets. They are available on the Australian Health website. It's a really brilliant leaflet. It goes through Meningococcal B vaccine, the risk of fever. It's got the little dosages for paracetamol based on body weight and how many mils are required, and when the doses should be given. So there's a definite increased risk of fever that's associated with the Bexsero vaccine. The first dose should be given within 30 minutes of receiving the vaccine, or as soon as practical after the vaccine's been given. So if someone's come to your clinic, they've not had paracetamol at home, then you should be able to administer that in the clinic at the same time as giving them the vaccine. And it's important that you make sure there's procedures in place. Within CHIS, we're working on standing orders for that, but out in general practice or Aboriginal medical services, you need to have something in place to make sure that this is just standard process that you do when kiddies are coming in for their Bexsero vaccination. And they are required to have 2 further doses. So they should have a dose 6 hours after the vaccination and another 6 hours after that. For anyone, parents that have any issues with the risk of fever and safety of vaccines, I've just popped in the top right left-hand corner there, the SKY, which is sharing knowledge about immunisation, and that's the NCIRS have this arm to their work that they do, and that's pretty much for parents. It's information for parents, and a lot of that's about vaccine safety. So if you find that you're getting anxious patients, I would refer them to that website. So a lot of the safety data regarding Bexsero has come from the UK. They've had this programme in place for a number of years, and in a surveillance study in 2017, of the 3 million doses that were given, there were less than 1% adverse events reported. And the majority of these were local reaction and fever. But throughout this study, the UK found that there were no significant safety concerns after widespread use of Meningococcal B vaccine in infants. Their schedule was the same given at 2, 4 and 12 months of age. With administration of the Bexsero vaccine, it's recommended to administer the Bexsero in a separate limb to other NIP vaccines where possible. So Bexsero does have a higher frequency of injection site reactions, so try to avoid administering this vaccine in the same limb as other routine vaccines. I've had a good look through the Handbook and the NCRS information, and it's okay, they all say that it's okay to give Bexsero alongside the other National Immunisation Programme vaccines. So vaccines under 12 months of age should only be administered in the thigh, and for infants over the age of 12 months, the deltoid is the preferred site for the Bexsero vaccination. If a parent insists on delaying the Meningococcal B vaccine, we do recommend a minimum 3-day interval between their routine vaccinations and the Meningococcal B. And we always would recommend that you give the standard NIP vaccines as a priority, and then come back and get the Meningococcal B a few days later. We do want to ensure that they're getting their standard NIP vaccines. There's just a little diagram there, that's actually taken from the Handbook, and just a reminder that injection sites must be at least 2.5 centimetres apart and document clearly where vaccines have been administered. So we're wanting to know if there's any adverse events to these vaccines. So if you are giving several vaccines in one limb, 2 vaccines in one limb, we want to know if which one was given in the upper and which one was given in the lower of the deltoid or thigh. It just helps us with following up adverse events. The poster in the bottom right-hand section, we have lots of these upstairs in our unit. So if you would like to have any on your wall, which does just help with vaccine administration sites, and it also says how many vaccines can be given in any one visit. So it's quite a handy poster to have when you're working out vaccines. So side effects. So fever is the most notable reaction in infants and young children, particularly when given the 2 to 12 months of age. Studies found temperatures to be highest 6 hours after vaccination. So that's where it's important that you're giving your post-vaccination advice. And the studies found that fever was less common by the time you're receiving the booster dose at 12 months. So it's going to be your young children who are also receiving the other vaccines that are probably more likely to have a reaction. There are a few other side effects that they found. Injection site tenderness, swelling, induration and erythema, irritability, sleepiness, unusual crying and a change in appetite are all possible side effects. They may not get any, they may get one, or they may get a couple. I touched on this briefly, but post-vaccination advice is going to be so important with Bexsero. This leaflet is brilliant. The one that says vaccinate to protect your baby against meningococcal B. It's going to be brilliant for their post-vaccination information, and also in preparation for when they come back for their next visit. So there's just a little bubble up there, says education prior to next visit. So you're probably going to have to do most of your education at that first visit at 6 weeks, 6 weeks to 2 months. But hopefully your subsequent visits, they should be more educated and able to know what to do. The following vaccination, what to expect and what to do, they haven't been updated yet. I've put them there. It's a bit disappointing that they haven't been updated to add Meningococcal B, but hopefully that will go on. But it's still a really good leaflet because it talks about fever, it talks about what to do, and when I give Bexero in GP world, I'll just handwrite at the top Bexero given date, and then it's just the same side effects that you're looking out for. So that was Bexero, and the other change to the immunisation is the paediatric hepatitis A. Fortunately, there aren't any great changes there. It's just been moved to accommodate the Bexero. So due to crowding of the vaccines at 12 months of age, Vactor, which is the paediatric hepatitis A vaccine, will now be given at 18 months and 4 years. So dose 1 when they come in for that 18-month visit, and dose 2 when they come in for their 4-year visit. So any Indigenous child presenting for their 12-month vaccines as from the 1st of July, they will not receive hepatitis A, and they'll have to return when they come for their 18-month vaccinations, and they'll get dose 1 hepatitis A at 18 months. For Indigenous children who have already received their dose 1 hepatitis A, their second dose, it can be given at 18 months or at 4 years or any time in between, so long as there's a 6-month interval. So if they are back for their 18-month vaccinations, or they come back at 2 years to receive a flu vaccine, if they've not received that dose 2 hepatitis A, they can have that. But once the children that are having the dose 1 at 18 months, it'll be 2023, by the time they're coming through, they'll actually receive their second dose at 4 years of age. So the change to the hepatitis A schedule, it's not expected to increase the incidence of hepatitis A in Indigenous children. So that was quite an easy change for that one, just moving the timing. So dose 1, 18 months, dose 2, 4 years of age, and then if children did receive it at 12 months, then they can have it any time, as long as there's a 6-month interval from the first dose. There are several changes to the pneumococcal vaccine. So I'll start with the changes in the childhood section, and then I will talk about the adult section, and then we'll talk about the medically at risk section, and Nancy will also touch on that as well. So the childhood pneumococcal vaccines that are available are Pneumovax 23 and Prevnar 13. So pneumococcal disease is caused by the bacterium Streptococcus pneumoniae, and it can cause severe invasive disease, including pneumonia, meningitis, and bacteremia. Invasive pneumococcal disease mainly affects young children, older people, Aboriginal and Torres Strait Islander people, people with certain long-term diseases, and people with a weakened immune system. The recommendations have been simplified to make pneumococcal vaccine more readily available to those most at risk of invasive pneumococcal disease. So for the childhood pneumococcal changes, Prevnar doses actually remain the same. So Prevnar for non-Indigenous children is given at 2, 4 and 12 months of age, same as previously. Indigenous children will receive it at 2, 4, 6 and 12 months, so they're getting that additional dose at 6 months, and the medically at risk will be 2, 4, 6 and 12 months as well. So both the Indigenous and the medically at risk children will be receiving that an additional dose at 6 months of age. There are changes with Pneumovax 23. So Pneumovax 23 has now been introduced into the children's schedule. And this is for Aboriginal and Torres Strait Islander children and medically at-risk children. They'll now receive Pneumovax 23 at 4 years of age. It can't be given any earlier than 4 years of age, and dose 2 will be given 5 years later. So The section at the bottom, I've just done a little snip of the National Immunisation Programme schedules that you're all going to receive. And if you look at the 4-year age group, there's the pneumococcal, which is Pneumovax 23. It's got an orange square because it's eligible for Aboriginal and Torres Strait Islander children. It's also got a purple square because it's available for medically at risk. So if you've got an Aboriginal and Torres Strait Islander child who is medically at risk at 4 years of age, they will now receive the DTP, hepatitis A and pneumococcal 23. And it's just got a little bit of information on the right hand side there, saying dose 4 years of age with additional dose at least 5 years later. So we've still got that 5-year interval between 2 doses of Pneumovax 23. So for medically at risk children, so if you've got a child that's over 12 months of age and diagnosed with a medical condition, they will receive a Prevnar 13 at the time of diagnosis. If in the yellow bubble there, it will say Aboriginal and Torres Strait Islander children under 5 years of age with a risk condition, they've already received that extra dose because they'll have already received, because of their ATSI status, they will have already received the Prevnar 13 at 6 months of age. So they will have had all their doses. Children under 5 years of age with a risk condition who have not received all the recommended 13 PCV, the Prevnar 13 doses, should receive doses of Prevnar 13 according to the ATSI medically at risk table. So it may be slightly different to if they'd received them under 12 months of age, because once they're over 12 months, they'll receive less doses. You need to work out, go on the table, work out how old they are, how many previous doses they've received, and what they still require. And then the other square just says the youngest age recommended for receiving the first dose of Pneumovax 23. First dose after the required Prevnar is 4 years of age. So you have to have received all your doses of Prevnar 13 before you go on to receive Pneumovax 23, and Pneumovax 23 cannot be started any earlier than 4 years of age. This is one of the infographics from the Australian Immunisation Handbook, and it just breaks it down quite nicely. You can see your routine schedule. They'll get the 3 doses at 2, 4 and 12 months of age. Then the children with medically at risk conditions and the children who are Aboriginal and Torres Strait Islander, they receive the 4 doses. And then if you move across into the purple section, you can see that they get 2 additional doses of Pneumovax 23. So that's new, wasn't on the schedule before, it is on the schedule now. And then the information, it's a bit of a bright slide, that we just want to get the message across that it is now only 2 doses in a lifetime. So the number of lifetime doses of Pneumovax 23 is now limited to 2 doses for all people who are recommended Pneumovax 23. Previously it was 3 doses in an adult lifetime. Now it's 2 doses throughout the whole of your lifetime. So if you've got a medically at risk child that has all the Prevnar 13s, they have dose 1 Pneumovax at 4 years of age, dose 2 Pneumovax at 9 years of age, Pneumovax 23 at 9 years of age. That's their 2 doses in a lifetime. They've had their doses required. And previous doses are counted as well. So if you've already got someone that's already had a Pneumovax 23, that's counted as whatever dose it was. There are changes to the adult pneumococcal tables, and these are the same vaccines that are available. So we've still got Pneumovax 23 and Prevnar 13, but eligibility and timing and age have changed. So I'll go on to go through the adult changes. If you've got a healthy non-Indigenous adult, they're with no risk factors at all, they're no longer recommended to receive Pneumovax 23 at 65 years of age. What they will now receive is a Prevnar 13 at 70 years of age. So pneumococcal disease is more common in those aged over 70 years than those aged in the 65 to 69 bracket. So they've moved it to 70 years, and that does align with their Zostavax vaccine as well. And unless a person goes on to develop one of the at-risk categories, no Pneumovax 23 is given. So a healthy, non-Indigenous adult, Prevnar 13 at 70 years of age, and no other pneumococcal vaccines. And there's a little square at the top there, which just goes on to say, Those who are already 70 years of age or older on the 1st of July 2020 are also eligible for a single NIP-funded dose of Prevnar 13. This can be given opportunistically at a suitable visit. So if you're doing your influenza vaccines and you know that this person's over 70, they've never had a Prevnar 13, they can have a Prevnar 13. So that's just opportunistically at a suitable time. Then for Aboriginal and Torres Strait Islander people, it's recommended that they receive a single dose of Prevnar 13 at 50 years of age. So not the Pneumovax 23, it's Prevnar 13 at 50 years of age. And this is followed by 2 more doses of Pneumovax 23. So they dose 1 of Pneumovax 23. They're recommending that it's given 12 months later, but it can be given as early as 2 months. So your first dose of Pneumovax 23 can be given 2 to 12 months after the dose of Prevnar 13. Dose 2 of the Pneumovax 23 is then given at that 5-yearly interval, and that's the 2 doses. So really important that you're checking the immunisation history for these clients. So the recommended interval between Prevnar 13 and that first Pneumovax 23 is 12 months, but as I said, it can be given in 2 months' time. If it's the other way round, if they've received a Pneumovax 23 first or within the last 12 months, there has to be a minimum 12 months before you can give the Prevnar 13. So that's important that when somebody's coming in for their Prevnar 13, you do need to check AIR or your own medical immunisation histories to make sure that they've not received that Pneumovax 23 in the last 12 months. And as I said before, Pneumovax 23, there are only 2 lifetime doses now. And doses of Pneumovax 23 received in the past are counted when you're deciding on further doses. So if you've got somebody who's already had 2 doses of Pneumovax 23 in their 20s and 30s, and then they come in at 50 for their Prevnar 13, they just get that Prevnar 13, no more doses of Pneumovax 23. And if a person has received at least 2 doses, as I said, no further doses. And all of this information, it's written on that ATAGI statement that's just over on the left-hand side. So there's a lot of information in that ATAGI statement. And just be mindful now that it is only 2 doses in a lifetime of Pneumovax 23. The online immunisation handbook that used to have Category A and Category B recommendations for pneumococcal has now been merged into one big long list. So the reason I've put this slide on the screen is just how to find that list. I still struggle with the Australian Immunisation Handbook since it's gone online and we can't just have tabs in our handheld book anymore. So if you're wanting to find this list, you go onto pneumococcal, you go to recommendations, and then you either go to the under 12 months or the over 12 months, and then you click on that, and then there's a long list of the recommended categories. Though that has changed because it used to be that everybody on those 2 lists were eligible for funded for pneumococcal, but now the new list, it gives recommended, everybody who is recommended to have a pneumococcal vaccine, but it's got a tick and a shaded area telling you whether it's funded or not funded. And in the handbook, it isn't actually ticks, it's just a tiny little letter, and it's very difficult to read. So the next slide is taken from the ATAGI statement. This makes it a lot clearer. So we've printed and laminated these for ourselves, so it'd be a good idea to do that and have that above your desks so you can see who is and who isn't eligible. So the list of risk conditions is in the dark purple there. That's a big long list. A lot of things there that have always been there. But what's different is the boxes that are shaded down the right-hand side, the one that are under 5 years and over 5 years, that's telling you whether it's funded under the National Immunisation Programme or not. And if it's not shaded and doesn't have a tick, it's not funded. It's still recommended because it's on that list, but it's not going to be funded through the National Immunisation Programme. And there's a little section at the bottom where the arrow is that just tells you that. And again, that ATAGI all these ATAGI statements, there's so much information in these, it's really worthwhile having a good read. And what it does say is that where the rate of disease is not sufficiently high enough to be cost effective, people will not be eligible to receive the recommended pneumococcal vaccine under the funded NIP. So as I said, doesn't mean that it's not recommended, it's still recommended, but unfortunately it's not funded. And you can see down there, diabetes and smoking, that was previously funded and it's not anymore. However, it is still recommended. So if you have got somebody who is medically at risk, they fit into that criteria. If they're adults or adolescents or children over 12 months of age with an identified risk condition, they are eligible to receive that one Prevnar 13 at the time of diagnosis, and then they go on to have the 2 doses of pneumococcal 23, which is a Pneumovax 23. Please check AIR for previous doses, because you may find that even though it's not in your medical notes, a lot of the people have been going to different services, their vaccination history will be different to what you have. This is another one of the infographics taken from the Australian Immunisation Handbook. They're just handy to have, just to give you a better idea of eligibility. You can see that just the standard schedule for non-Indigenous and non-medically at risk, you've just got your 3 doses. However, once you get onto medically at risk, you can see that it's the additional doses of Pneumovax 23, and then on the far right you've got a non-Indigenous adult at 70 years of age who just receives that 1 dose of Prevnar 13. However, if they then go on to develop a medically at risk condition, they'll move into the medically at risk category and they will get the 2 additional doses of Pneumovax 23. So I'm just going to show some of the other sections from that page 2 of the schedules. So we're just looking at some of the other vaccines. And for the older adults, we just have to remember that they're also eligible for Zostavax at 70 years of age. Again, always check AIR. We don't want people to receive more than 1 dose of Zostavax. And that's given at 70 years of age at the same time as a Prevnar 13. And with the Zostavax, it can safely be given with Prevnar 13, and if someone's requiring Pneumovax 23 as well, it can be safely given with Pneumovax 23, and it can be safely given with influenza vaccine. So this is part of that top section on the second page, the adolescent and adult immunisation, national immunisation schedule. Then this is the section also on that adolescent and adult page. I've just got a lot of information there, but I've got quite a few things that I just wanted to point out. So with the year 7 students, they get the HPV, the Gardasil 9. That's given in the school programme, but you may find that you get in adolescents that haven't been receive their vaccines in school, so they're coming into your general practice. If they do, again, check the handbook, check how many doses they're due, because if a child is over 14 years of age and they're starting the HPV course, they do need 3 doses. So under 15 years of age, they only have the 2 doses 6 months apart, but as soon as they reach 15, if they're starting the schedule over the age of 15, they will need 3 doses of the HPV vaccine. With the diphtheria, tetanus and pertussis, so in the school-based programme, they receive Boostrix in year 7. If they haven't had that Boostrix in year 7 and they're coming into your GP practice or your service for catch-up, just be mindful that you use the appropriate vaccines for adolescents and the appropriate catch-up schedules. So your Influenzas, Hexas and IPVs, they are not appropriate for adolescents. As soon as a child turns 10 years of age, they're not receiving any of those childhood vaccines, the tetanus containing vaccines. As soon as they turn 10 years of age, it will be Boostrix or Adacel, just because we've had a few errors recently, so we just wanted to reiterate that. And their catch-up tables are different from the under 10 catch-up tables. Their intervals and dosage are different, so make sure when you go on the handbook that you're looking at the correct age, and make sure you're giving the age-appropriate vaccine for that catch-up schedule. Year 10 students, they receive meningococcal ACWI. That would be given in school, but if they don't receive it in school, they can have a Nimenrix outside in general practice or in wherever your service is. Pregnant women, so they should receive Boostrix or Adacel between 20 and 32 weeks gestation. It can be given later than 32 weeks, but no earlier than 20 weeks. And 20 to 32 weeks is the optimal time for protection. And if they're also due influenza, they can have the influenza vaccine that can safely be given at the same time as the Boostrix or Adacel. And down in the bottom section there, the MMR vaccine, just a reminder that any person born during or since 1966 who does not have 2 documented doses of MMR vaccine are eligible to receive funded MMR. Sorry, it's a very busy slide. Also, just wanted to point out, so the section in purple is the medically at risk section, and that's the section that Nancy is going to talk about. In the green square, this is on the adolescents and adults schedule. It just tells you who's eligible for influenza. And just a reminder that for a woman who received an influenza vaccine before becoming pregnant, you do revaccinate during this pregnancy to protect the unborn infant. And you can also continue to offer influenza throughout the year. Whenever you've got it in stock and it's in date and somebody hasn't been vaccinated with influenza, you can continue to offer that vaccine. So that's in the bottom left-hand section of this adolescent and adult schedule. Over to the right, there's the refugee section, refugee and humanitarian entrance. This had its own schedule in the last schedule. It's just in a tiny little box at the bottom. But just go onto the handbook. It has got the catch-up schedule, and it tells you there which vaccines they're eligible to catch up on. So you've got your DTPs, chickenpox, polio, MMR vaccine, and hepatitis B. So that's for over 20 years of age. Under 20 years of age, they'll just receive our standard adolescent or childhood schedule. And then you can barely see it, but just underneath the purple medically at risk, there's just a line there that talks about catch-up for adolescents. So again, the previous schedule had its own page for adolescents, whereas now it's just that one sentence. And it's saying which vaccines adolescents are eligible to catch up on, funded catch-up, and go to your catch-up schedules in the handbook and age-appropriate vaccines. So that second page of the adolescent and adult schedule is a very busy page, so I would recommend reading it really carefully and having a good look, because a lot of things are written quite small in that schedule. So Nancy is going to talk about medically at risk and also cold chain. I'll pass you over to Nancy.
Okay, thank you. Now I'm going to be talking about the changes to the recommendations and funding for medically at risk. So having a look at this slide here, this table shows the changes that are coming as of the 1st of July 2020. The diseases that are changing for medically at risk conditions include pneumococcal, meningococcal, Haemophilus influenzae type B. So it's only some people that are medically at risk, but we'll talk about that in the next few slides. So firstly, we're going to look at the meningococcal disease. So there will be new NIP-funded meningococcal B and meningococcal ACWI vaccines for people of all ages with the following 3 medical conditions: functional or anatomical asplenia, defects in or deficiency of complement components, current or future treatment with eculizumab. As you can summarise, these groups of people that are now funded are a very small number of group, so you really need to look at the medical conditions and the funding for this group of people. They are a very important group to vaccinate. The recommended meningococcal schedule for the medically at risk of those 3 categories, the best part is it's the same schedule, whether it be for meningococcal ACWI, which is our Nimenrix vaccination, or our meningococcal B vaccine, our Bexzero. It all really depends on the age that they start the vaccination. So if the age of starting is from 6 weeks to 5 months, the number of total doses required will be 4. It's really important to look at the minimum intervals between the doses. So there's 8 weeks between the doses, and then the 4th dose should be given at 12 months or 8 weeks later, whichever is the later date. If we start the vaccination at 6 months to 11 years, there will be a total of 3 doses required. Again, there's that 8-week interval between the doses, and the third dose needs to be given at 12 months or 8 weeks after the second dose, whichever is later. If, however, they start the meningococcal schedule over 12 months or equal to 12 months of age, there is 2 doses required, and they are to be 8 weeks apart. So meningococcal vaccine booster doses, is this required for our medically at-risk population in those 3 categories? Booster doses of Bexzero, the Meningococcal B vaccine, is currently not recommended, not required at all. However, the meningococcal ACWY, the Nimenrix, those with ongoing increased risk conditions of invasive pneumococcal disease, so those 3 conditions we mentioned earlier, are now NIP funded for booster doses. And again, the booster dose depends on what age they completed the primary course. This is all information found on the ATAGI Statements and the Immunisation Handbook. So if they completed the course less than 6 years of age, you give a booster dose 3 years after completing the primary schedule, and then every 5 years. If they completed 7 years or over, you give a booster dose every 5 years after they completed that primary schedule if the condition is ongoing. There's also new NIP funding for Haemophilus influenzae type B Hib vaccine. This is added to the NIP schedule as of the 1st of July 2020 for those individuals 5 years and older with asplenia and hypersplenia. The reason we say 5 years or older is because the ones under 5 should be receiving their vaccines as per the childhood schedule. Now, they require a single dose of the Hib vaccine, ACT-Hib, if they've not previously been vaccinated or were incompletely vaccinated. And booster doses of Hib are also not required. Again, more information can be found in the Handbook or ATAGI Statements. Angie did mention the pneumococcal program, and I also will discuss the pneumococcal program with really looking at the at-risk schedule. As you can see, the 3 different programs, the infant, the older Australian and the at-risk schedule can overlap. So sorry if we are saying the same information twice. At-risk schedule for pneumococcal, feedback from providers was that previous schedules and recommendations were too complex. Nobody really knew whether category A or B were to be funded, how many doses should be given. So the feedback was to create this one list. So there's our one list of risk conditions. This one's taken from the National Immunisation Program leaflet that's available. And the only difference to this one list is making sure who is funded and who's not funded. But at least it gives us a clear idea of who should get vaccinated, when and which vaccine they should get. As you have already previously been mentioned, not all conditions will be funded with the National Immunisation Program schedule for July 2020. More information definitely from the ATAGI, and there's the list again. And if you look at the list, as Angie did mention, there is the shaded section and the age eligibility. So refer to that with every medical condition that we find. I will discuss the schedule. So anyone over 12 months of age who is diagnosed with a risk condition for pneumococcal disease, there's the list of risk conditions there on that side, on the left-hand side. They should receive a Prevnar 13, a single dose at diagnosis, and then you get your Pneumovax 23, dose 1, 12 months after the Prevnar 13, or at 4 years, has to be over 4 years of age, whichever is later. As Angie did mention, you can have that 2 months later, 2 to 12 months. And then you get your dose 2 and Pneumovax 23 at least 5 years after the first dose. As you can see on that risk conditions for eligibility table, there's a little green stars that you'll find, and they're for the pneumococcal vaccines funded for 5 years and under. So if they're over 5 years of age with those conditions, they're not funded under the National Immunisation Program, July 2020. We also want to really point out that the number of lifetime doses of Pneumovax 23 is now limited to 2 doses for all people. And that includes any Pneumovax 23 given in childhood, adolescent, early adult. They're all included in the lifetime. And again, I just want to point out the youngest age recommended for receiving your first dose of Pneumovax 23 is 4 years of age, no younger. This is the National Immunisation Schedule for adults and adolescents, and the purple section just on the bottom is where we're going to find our information for medically at risk. Angie's gone through that really nicely, so I'll let that one go. So to sum up, if a person has already received, based on previous recommendations, at least 2 doses of Pneumovax 23, then no further doses are to be given. So it's really important to check it. For those who have previously been vaccinated with Pneumovax 23 and are eligible with this new schedule that's come out on the 1st of July 2020, for a Prevnar 13, the minimum interval needs to be 12 months. So they do need to wait the 12 months before they get that Prevnar 13, even though they are now eligible. Providers should ensure to carefully screen all patients to determine if they have either risk conditions for pneumococcal disease or medical conditions that increase their risk of invasive meningococcal disease. And you've got to note that not all these medical conditions listed will be funded. So we really need to look at the ATAGI statements as well for that. Before vaccinating, review the online handbook or the handbook app, check your eligibility, and most importantly, check AIR for immunisation history and your own records. If it hasn't been documented, then we would say it hasn't been given. This is the decision tree for vaccination providers, really quick and easy way. It's just 2 pages. Have that one available so you can work out who's recommended, who's funded, and how many doses and what doses. And again, if they've previously had that Pneumovax 23, repeating the dose is not required. But if it's not been documented as given, then it's not given and you can receive the Pneumovax 23. Just because this is all new for everyone, I wanted to give you a quick scenario. This scenario is of an Aboriginal Torres Strait Islander with risk factors. So I've picked Marjorie Harry, who was born on the 29th of the 6th, 2002. She's going to present on the 14th of the 7th, 2020. And at that stage, she will be 18 years of age. She has a medical history of type 2 diabetes that was diagnosed in 2017 and left untreated. And earlier this year, she had invasive pneumococcal disease, was quite unwell with it, as per my scenario. So her past pneumococcal vaccination history, she was on the Prevnar 7 schedule, given that at 2 months, 4 months and 6 months of age. She also received the Pneumovax 23 at 18 months. Again, this was the schedule back in 2002. So what we want to know is what her medically at risk vaccination plan would be today. First of all, we need to know if she is eligible for any medically at risk pneumococcal vaccines. And what you can see from her medical history is the invasive pneumococcal disease. This is new to the list of risk factors, and it's a really important one to review, because anyone who has previously suffered from invasive pneumococcal disease is of high risk. So she definitely meets the criteria. The type 2 diabetes does not meet the criteria. So she will receive on the 14th of the 7th, is eligible for that Prevnar 13 single dose. She has previously had Prevnar, but it was Prevnar 7, so she can get that Prevnar 13 on the 14th of the 7th. She will also require that Pneumovax 23. It'll be dose 2, therefore she'll have nil further doses after that one. When will she require that? That's going to be 2 to 12 months later. So we can give it 2 months later, but it can be up to 12 months later. Now we know we're all talking about pneumococcal and medically at risk scenarios, especially having someone this young recently have invasive pneumococcal disease, but we should also check AIR to check all other eligible vaccines that she may be eligible for and to be given opportunistically today. And that includes influenza vaccinations and because she's 18, even any high school vaccines that she may have missed out on. Okay, so moving from medically at risk, I'm now going to touch a little bit on cold chain, vaccine storage and management. The National Vaccine Storage Guidelines, STRIFA 5 3rd edition, this little one here, was released in June 2019, so it has been 12 months. So as the publication title states, the STRIFA 5, we're striving for 5 degrees Celsius. This is the midway point between 2 and 8 degrees, which is the recommended range for vaccine storage. With the new immunisation schedule that's been released on the 1st of July, many places, many vaccine service providers will need to reconfigure their purpose-built vaccine fridges to fit in yet another vaccine, our Bexero. So it's really a great time now to have a look at what your fridges are looking like and to recap on the changes that came out last year. There are 3 important key changes that occurred last year that I want to recap on, as well as visit some crucial issues of vaccine storage. Key change number 1 is in section 3, types of refrigerators for vaccine storage. Domestic fridges must not be used for vaccine storage. The STRIFA 5 2nd edition that was released in 2013 did mention the use of domestic fridges, but this has now been entirely removed. Great job here in Far North Queensland. All our vaccine service providers do use purpose-built vaccine fridges as their principal storage of vaccines. So that's fantastic. However, in the last 12 months, us here at Tropical Public Health have had to deal with 2 cold chain breaches where vaccines were placed in a domestic fridge, resulting in total discard. As you can see in that picture on the right-hand side, as an alternative storage, the vaccines were quickly placed into this domestic fridge. This does completely mean these vaccines will need to be discarded, and they were all discarded. So we regularly remind our service providers that domestic fridges must never be used for vaccine storage. This is mainly done with your vaccine management protocol, your VMP. When we do get them to review, sometimes it is noted when cleaning your vaccine fridge to place vaccines in an alternative fridge. It doesn't mention the alternative fridge should be another purpose-built vaccine fridge. So if your vaccine, if your service, your clinic does not have 2 vaccine fridges, purpose-built vaccine fridges, then you should remove that from your vaccine management protocol, because you will not be able to put it in another fridge, because the only other options are the domestic fridges. This can confuse new staff members, so it is best just to remove it from your protocol. And just remember, vaccines can only be stored in purpose-built vaccine fridges, or portable purpose-built vaccine fridges, or a prepared cooler, our ESCIs. Key change number 2 that came out in the new STRIFA 5 3rd edition was section number 4, vaccine temperature monitoring requirements. Purpose-built vaccine fridges must be continuously monitored using a data logger. Most already have this set up, however, for others this may be a new concept. So this came out last year. It is recommended that everyone review their vaccine management protocol and processes, read this section and just ensure that you are complying with the current national guidelines. It is important to note, even with continuous monitoring, twice daily min-max temperatures must still be manually recorded on the Queensland Health min-max chart. This just helps check for any conditions and alert of any cold chain breaches. Another thing to note is those with the Quirks MediSafe purpose-built vaccine fridge, the data logger is actually part of your standard equipment provided. So the min-max temperature display is to be used as a guide only, and your min-max that you record on your min-max chart needs to come from your data logger. So this is the Queensland Health min-max chart that we ask that all our service providers record their temperatures. It's a great chart because it really helps if you do have a temperature outside of that 2 and 8 degrees. It will record in a red section and prompt you to do something about it. It also gives the prompt of doing twice daily temperature checks, AM and PM, and on the back of this you can also add extra information if you do have temperatures outside of the range of 2 and 8. The next key change, number 3, is from section number 7, caring for vaccines during immunisation clinics. This really helped because we needed more additional information when we did outreach immunisation clinics regarding transporting of vaccines. So it's a great section to look at if you do any outreach immunisations. And also really clearly explains the recording of the min-max temperatures when you're packing your cooler, also during the clinic and also upon returning to your clinic, ensuring to reset your thermometer after each reading. We also have many practices that doctors order private vaccinations for, and we do get phone calls regarding them. This section provides clear information on instructions for doctors who provide a prescription for the purchase of vaccines, ensuring what to do with these vaccinations when they come from pharmacy. I also just wanted to give you a cold chain overview that we've had for Far North Queensland for the first 6 months of the year. So as of today, we've had 74 cold chain breaches. We did get one just yesterday. The total cost is so far to date has been over $48,000. Now we've got to remember this is government priced vaccines, so privately purchased vaccinations will be at least 3 times that amount. But what's important with cold chain breaches is the cause of the cold chain breach, because that way we can try to prevent more cold chain breaches. And if you have a look, most of the cause has come from power outages. There is a bit of human error, fridge malfunction and equipment failure. If we look at last year's, during the same period, so January till June 2019, we had 62 cold chain breaches, total cost of over $34,000. And again, mostly due to power outage, human error, some fridge malfunction and equipment failure. So what you can note is our cold chain breaches are increasing in number and the costing is also increasing. So we really need to plan ahead and think of alternative storage solutions for power outages. Really, it's about having a good plan ready to go to prevent that costing to go up, because power outages will always happen, but if we can reduce the costing or keep it at a same level, that'll be great. So managing a power failure, the safety and well-being of staff should always be the main priority. We definitely do not expect any heroics, but you should also have a solid backup plan. Everyone's plan is different depending on your own resources, the area where you work, there's buildings, whether you can come in or not, whether you have a back door, whether you have lighting. So we can't really give you a plan to manage a power failure because you really need to go with what works with your clinic, and that's why it's best to have that backup plan and practice it. We also need to make sure all staff are aware of the backup plan and know what to do should there be a power failure or a fridge malfunction. Practicing is probably one of the most important things to do, at least yearly, and especially when you get new staff members. On the right-hand side is a photo of a clinic where the fridge malfunctioned. Therefore, instead of putting vaccines in a cooler, they were placed in this domestic medical fridge. So it was for medicine, but it is a domestic fridge. And again, those vaccines had to be discarded. We also say never to transport vaccines without a min-max thermometer or a data logger to monitor the temperatures. And again, just do not store your vaccines in a domestic fridge, including bar fridges and camp fridges, even though camp fridges do have temps. Where we do have alternative storage would be our coolers. So it's a great idea to look at section 9. We really need to ensure that we have coolers that meet our clinic's needs and have a tight fitting lid. Most clinics are going to now receive extra vaccines, have extra Bexero in their fridges. So you need to make sure you have a cooler that will fit the number of vaccines stored in your purpose-built fridges. And if not, purchase more coolers. And if you do have more than one cooler, then ensure you have enough equipment. Adequate ice bricks, bubble wrap or paper, so insulation material. You need to have min-max thermometers for each cooler. So if you have 2 coolers, you need a minimum of 2 min-max thermometers. If you have 3 coolers, then 3 min-max thermometers. We do recommend a temperature logbook for each cooler. They are available from the immunisation program unit when you order your vaccines. So that's that blue one there on the slide. And ensure that you do your slush test and change your batteries at least yearly for your min-max thermometers. As you can see on the bottom slide, we write down on the back on a little sticky note the date that we changed our battery and the result of our slush test. We also have available at Tropical Public Health this emergency vaccine storage sticker that you can order from us for your cooler. It's just a really quick guide, nice and easy. So in an emergency, you've got something quick to look at on how you're going to pack your cooler. Most importantly, pre-chilling that cooler with those ice bricks and then having other ice bricks conditioning ready to be used to pack your esky. So if you need any of those, just give us a call. Purpose-built vaccine fridge storage and space. Again, this is quite important because we are getting more vaccines in your fridge. So we need to make sure we have a plan on where these vaccines are going to be stored in the fridge. We do not want to crowd the vaccines by overfilling the shelves, so plan now for those extra vaccines. We do ask that you store your vaccines in open weave plastic containers with a solid base. So something like this open weave plastic container that has these lovely little pictures so we know where we're going to put our vaccines, and they have little sections to put your vaccinations in. So we do ask that you keep your vaccines in their original packaging. This is extremely important to protect the vaccines from light because they do get damaged from light. It is also a great idea to label your plastic containers and all the shelves with the names of the vaccines that are stored on them. This helps for when you're finding the vaccines that you're looking for, and prevents you from keeping that fridge door open for too long, causing possible cold chain breaches. Ensure that your purpose-built vaccine fridge is maintained and serviced annually, and check that your vaccine management protocol or your workplace instruction is up to date. Us in Cairns at TPHU are really happy to review and provide comments and support when you do update your vaccine management protocol. Just email us the protocol and we'll email you back with any comments that we may have. These are the lovely baskets that we definitely do recommend that are used, because if you look at the picture of the fridge on the right hand side, you will notice the first few shelves have plastic containers where the vaccines are stored in. Therefore, there's very minimal air circulating around those vaccines. Whereas the bottom shelves, the vaccines have been placed there. Yes, there's a label, but those vaccines can easily get pushed to the back on the cool plate, just damaging those vaccines, or even fall and get misplaced. Therefore, we definitely recommend baskets to be used. There are plenty of resources out. We do have those stickers available for your PowerPoints or for the door. We do have magnets also available for those that have solid door fridges. I also have produced A4 sheets of all the vaccine pictures that we can email to you, that you can print out yourself and label your baskets with. And as anyone that has anything to do with vaccine management, we do recommend course 2, the online immunisation course. It is free and funded. It doesn't just have to be the nurses, anybody that has anything to do with vaccine management, including your admin officers and the doctors, can complete this course. It's free and is really great information on it. Again, remember, we're always here to support your clinic.
Okay, so we're almost done. Just got a couple more things. Just want to get a few messages across before the end. So, because we're introducing a new vaccine onto the schedule, we're really keen to know about any adverse events. So please just continue to complete the adverse event following immunisation forms. They are on the website, the Queensland Health website, but also if you just type in adverse event QLD, these forms will come up and it tells you where to send them to. So they're very useful information for us and the vaccine companies as well. Software updates. They don't always happen overnight, unfortunately, but you really need to make sure that your best practice medical director, whoever you're using, has updated to the new schedule, so that as you're typing in your X0, we want to know that that's been filtered through and going to appear on air. So it's usually your practice manager that you have to speak to, and they'll get in contact with the software company. And really important that we know that these vaccines have been given and it's filtering through to air, because if somebody goes on to use a different service provider, they want to just be able to look on the Australian Immunisation Register and know what's previously been given. So if you could all get on board with that quickly, that really helps everybody. Resources, there's been so many with this schedule change. The ATAGI are probably the best information leaflets to read at the moment, because they just spell everything out. Those National Immunisation Programme information leaflets have been really helpful as well. The NCIRS produce fact sheets, and the NCIRS have also done a webinar which was live last Tuesday, and the recording is available for download now. And their webinars are always interesting because they go into a bit more about the science of the vaccine as well. There's the links to all those ATAGI statements. We are going to give you a resource list as we email this education session out. We'll send a resource list, but hopefully you should have had access to most of these already. The Australian Immunisation Handbook is what we refer to for everything, and it is now available as an app as well, so it's really handy for probably more remote and outreach work, but from what I've heard, it's very user-friendly. The online education, we're still really trying to push that. We really want everyone to get on board and do this. It's just great for your CPD, but course 2 is the vaccine management course, and the vaccine management is anything related to cold chain, really important. But there's one for catch-ups, there's a data one, and there's an administration course. They're free. They've been made by the Queensland Health Immunisation Programme, so they're relevant to our schedule and how we practice. And there is going to be a catch-up calculator that's going to be available from July, and it is actually going to be accessible via the handbook. So look out for that. And the certificates this time, we're using Eventbrite again, which is what we used last time. If you have any difficulties with this, just email our tphucdc_ims email address and we'll ensure that you get a certificate. But the method that we would like you to do is to go onto Eventbrite, look for the July 2020 NIP update. You purchase a ticket, they're free tickets, but you click purchase, it's free, and basically your name goes onto a list that gets emailed to us, and then we'll email you a certificate from our TPHU email address. And if there's any problems, just email us and let us know, and we'll just ensure, because everybody needs it for their CPD and credentialing. Okay, so that concludes our presentation. Because we're not in the auditorium and we can't answer your questions as we present this, we'd like you to email us with any of your questions. If you could email tphu_cdc_ims@health.qld.gov.au. That's our share email that all of public health nurses involved in immunisations read. So just email your questions. We'll get back to you as quickly as we can. We've already asked the NCRS, the immunisation programme, several questions of our own, so we're taking a while just to get through these schedule changes, but any questions that you ask, we'll endeavour to get the answers to you as quickly as possible, and hopefully as time goes on we're learning more and more about the schedule and we'll be on top of it by the time it comes out. Thank you.